unable to hear you. So depending on what it is, I mean, some people actually get real bad infections when they're children, and I know some, they'll try and actually drill holes and let them, actually allow the infection to, or the pus to come out, to drain out. But sometimes they don't, and the infections get so worse and they can't hear. So since sensory neural is that this is the hard part, okay? This is all basically damage into here, the actual neural structure and actual sensation, the cochlea and all that business. That's, I mean, like I said, that's usually something they're born with. That could be a medication induced. I mean, like for example, like aspirin. I don't know if you guys know, if you take a good aspirin overdose, one of the first things you can recognize is that they have what's called tinnitus, ringing in the ears. Things like that. Tumors and infections. Aging, obviously. Guys, you got to remember your anatomy and physiology at all? With the hairs, they can actually go like this as you get older. Okay. So that's just kind of remember this when you're kind of dealing with, somebody who's hearing impaired, trying to figure out what are you kind of dealing with. Obviously, it's a structural thing. It might be just, hey, this is temporary. They may be just kind of panicking. Obviously, it's a, sensory neural. This is something obviously permanent at that point. Obviously, the big thing here, so have hearing aids for diction, inability to respond to verbal communication in the absence of eye contact because of reading your lips. So, big thing here to point out for assessment, help you with assessment is, well, if you can't find the hearing aids, get pen and paper. That's really one of the best things that will help you. Position yourself where the patients can read your lips. You don't need to, what's the word, over-exaggerate your words. They're used to, chances are they're probably used to reading lips, and when you start doing this to try to, can you see what I'm telling you? That's probably more going to throw them off, if anything. So just speak normally like you normally would, and they'll probably pick it up pretty quick. But other than that, use of amplified listeners. Have you ever seen how many people talk loud to people that are deaf or can't speak English? Yeah, don't, you're not going to solve anything. The only thing that could be kind of frustrating is, honestly, if they're not very cooperative, because then you don't know why are they not cooperative. Is it because is it a hearing issue and they don't want you, because I mean they're normal people too. They don't want you to bother them, or is there something else going on? This little thing's kind of keep in the back of your mind. I don't get this one.
He has a mustache. Oh, he's a big mustache.
Oh. So, anybody here know sign language?
Well, the alphabet, that's about it.
Yeah. That's actually, sometimes they'll help you out.
International sign language.
Yeah. From what I understand with sign language, I mean, they actually have their own little accents, depending on regions, areas to area, little things like that. But, if you have sign language, great. If you know it, great. If you have somebody there who can interpret, even better. Obviously, don't shout. So 80% is usually a loss of high-pitched sounds. Again, don't exaggerate lip movement. So, visual impairment, again, it could be congenital injury, cytomegalovirus, glaucoma, or just degeneration in neural pathways. And again, obviously, they have glasses of some sort. Except they can't see you or can't see at all. Describe what you're doing. Okay? Because I mean, the best way to think about it is just being blindfolded and all of a sudden having hands all over you, or things poking and prodding you. So let them know what's going on as you're moving along there. Provide sensory information. Obviously, it's like, hey, I'm about to stick you with a needle. Sometimes best to sit there and kind of tap them with it. Say, I'm going to stick you right here. And then go 1, 2, 3, go. So if ambulatory, guide by leading, not pushing. Guide dogs, a lot of times they tend to be a little, if they can get up and walk and they actually have their stick, they usually will prefer just to don't touch them, let them do it, and say, hey, I'm just going to help you along. But if you actually grab them, they actually can get very insulted by that. Speech impairments, language disorders, articulation, voice production disorders and fluency, aphasia, like I said, stroke, head injury, The big thing here is just kind of remember, if you run into that person that for whatever reason can't speak, or they're speaking very garbled, that's always thinks that either if it's something new, something's going on up here, okay, for whatever reason. Strokes really, midbrain strokes really like to do that, you know. I mean, I can think of one guy. He had a midbrain stroke, and of course, the thing is, I guess what's really frustrating in his mind, he's making sense, but when he comes out, it's come completely just this whole word salad business. And I remember this guy was just like, he was trying to get himself dressed so we can take him to the hospital, and we're like, no, you need to go right now. So, but just kind of remembers that just because their speech center's knocked out, they're very coherent at that point. That's probably the more difficult person to deal with, because they don't know what they're saying doesn't make sense. And that's kind of, like I said, trying to convey, like, hey, I'm trying to help you out here. And they're probably saying, hey, I'm fine. Why are you doing this? And you're like, you don't understand, you're not making sense. And that can inhibit, obviously your rapport with the patient there. So understand basic etiologies: tumors, delayed development, hearing loss, emotional disturbances. So recognition, slowness, understand speech, slow growth of vocabulary. Dysarthria. Again, this could be damage to the from neural pathways to the muscle, larynx, mouth, or lips. Again, like I said, for whatever the case may be. I mean, have this slur speech. I mean, obviously, some people that have very low hearing, if they'll talk, they don't hear the high pitch. So when they are deaf, so when they talk, they have that very low pitch because they can't acknowledge that high pitch. So other disorders just kind of be aware of, the things that affect the vocal cords. Did anybody see, like in the news about 2 months ago, they had a lady, she contracted a virus, and one side of her vocal cords was paralyzed for like 20 years. Yeah. Yeah, and then, the point was that they actually were able to get in there surgically and actually get her voice up. Other than that, she was like, oh, he's talking like this. So, recognition, obviously, they're hoarse, harsh, inappropriate speech, abnormal nasal resonance, as time before. Fluency disorders not really understood, like stuttering. I mean, there are people that, we all stutter at some point, but some people have really severe stuttering. And understand it's just little things that kind of inhibit. You got to be very patient with this at that point when just talking to them. So allow patients time to respond, provide visual aids when possible. Like I said, if there's a faster means, like it says, hey, I'm drawing something or feeling something or whatever the case may be, go the faster route. Like I said, it helps along the assessment at that point. And like I said, if you're looking here, we're actually looking at just communication barriers. So we're just trying to overcome communication barriers at that point. Obesity, obviously, increased calorie intake versus calories burned. Low metabolic rate, they could be having thyroid problems. What do you think would be a problem with assessment and obesity?
I mean, be able to palpate, listen.
Can't hear their lungs, can't palpate the belly very well. Like I said, a lot of adipose tissue in the way. Like I said, I think we touched briefly on Pickwickian syndrome. I think some of these guys can actually get a little bit of compartment syndrome in their legs and so forth. So, thing is, there's a genetic predisposition. I think there's some South Pacific. I want to say, was it Guam? I think it's them that actually have a predisposition. Oh, Samoans have a predisposition to being, very heavy. So just make sure main thing with that, just make sure you get appropriate size blood pressure cuffs. Be professional. Obviously get assistance with lifting and moving. So. Paraplegia, obviously, we're looking at weakness or paralysis of both legs versus quadriplegia. We're looking all the way down. What are assessment issues we're going to deal with these guys? What do you think? How would you alter your assessment with a paraplegic?
Well, you can be like, you have any pain here?
Well, if they say no to here and they're paraplegic, I'd be kind of concerned.
Oh, for paraplegic? I'm sorry.
I wouldn't worry as much about the bottom half of them. I mean, decreased circulation and stuff like that is going to be common.
You have to visualize and see if anything's wrong with
Yeah.
the picture. I mean, no, you can't really See anything else? You got to visualize. it.
Probably more worried about their legs because they can't feel, so they're going to tend to have more breakdown,
ulcers,
stuff like that, ulcers.
Something hit them or
Yeah.
something, I mean, they're not getting done.
Yeah, just keep in mind of those things when you're doing that. And like I said, same thing with the quadriplegic. You know, actually one thing you're going to run into, especially with the quadriplegic, a lot of depression with these guys. One guy, I remember we were taking him to Colorado, we were taking him to a doc's office. He was 30 some odd years old, but he got his neck broken at 16 from a car accident. And I remember he started talking to his sister about, you know, how he's never going to get married, how he's never going to, I mean, it was depressing. I mean, it was just downright depressing, but I mean, that's all they do is they just lay there day after day. So just be careful. You're going to be dealing with a very, very depressed individual, quite, you know. But yeah, it's all the things that they can't feel, so you got to go look for. And that's what you really kind of need to get out on that one. So, what do you think about this? A halo. How is this going to alter your assessment?
If they have airway issues, you can't really open their airway for them.
Yes and no. You're going to be creative. You're going to have to be creative at that point.
Well, their neck's, you know, in neutral position, so it might actually be either.
You
You
can
know,
still get something in.
Yeah, it's just obviously you just got to work around the.
Equipment.
Yeah, that's all that really is to it. Then obviously there's obviously a pre-existing spinal condition that's trying to heal.
Gotta be gentle with it. Gotta be gentle with the patient.
Yeah. So, I remember actually, speaking of that one, of 820? I guess it was 18. 18-year-old girl actually, remember we're doing it again, Colorado, doing a transfer, and she drove her car off a ridge and lived. She was a suicide attempt, but she was in one of those. So, tracheostomies, tracheas. Just remember, like I said, that's what I talked about. Trachs from we talked about last go around is like I said, infections. Those things love to get clogged, and like I said, that and especially when it comes to assessing airway, you got to get on top of that pretty quick. I'm not going to get too much into bladder and colon on this one. Mental illness. Psych disorders. Psych disorders can make very, very challenging patients. Like obviously I was telling you about the schizophrenic. Okay, what's reality and how much can they convey to reality? And how much? I mean, let's say the guy's schizophrenic and he's actually hurting. And something's actually hurting. There's something wrong. How does he convey that? How do you find that out? You know, those are little things you just got to kind of learn to sit there. And obviously, it takes a little patience, but you got to sit there and say, I'm going to dig a little deeper and start, you know, make your actual physical assessment more in depth. You know, so maybe start, you know, more additional diagnostic tools like EKG and all that other stuff to kind of figure out what's going on. So just a big thing, like I said, recognize the barrier here. So psychosis, patient not really, patient's perceptions of reality radically different versus neurosis. Patient perceives reality normally but reacts to it inappropriately. But yeah, so I mean, if you're dealing with somebody with psychosis, I mean, a lot of times when we think of psychosis, you know, they're going, you know, violent, crazy. Not always. They're just not in touch with reality at that point. So again, like I said, how do you assess a patient like that? You got to just establish common ground. Neuroses, at least they perceive normally. They're just going to be acting inappropriate. I remember having one guy who, for odd reason, he'd just start like quack in between the sentences. But he was very with it. And he just started doing these quacking noises. Yeah. So, what about other mental illnesses out there? What are some of the other ones?
Bipolar.
Bipolar. How would that affect your assessment?
They could be really nice to you to begin with and then really angry.
And they might change their mind. But check.
That's actually not bipolar.
That's borderline
That's-
personality disorder.
Yeah.
Well, I mean, they may be on their, you know, depressive state. They're not depressed, but you may be treating them as depressed, but they may just be in that state of their
Yeah.
manic depression.
Well, what do you think depression would do to you symptomatically or assess? How do you think that could affect assessment or patient complaining of, you know, different ailments? I'm really depressed and I've been sick for the last week. They might over-exaggerate it, think they're dying, this is something terminal. I mean, little things to kind of keep an eye out for. Now here's the flip side, what if they're manic at that point? And they say, yeah, I got this chest discomfort or something like that, or it could be. Just remember that kind of that teeter-totter when you're kind of dealing with that.
Like depressed people also, they might not want to have it.
Yeah, they may not want your help, or they may not want to do anything about it. So the communication barrier exists again. So. Big thing here, just don't be afraid to ask about mental illness. A lot of times they're pretty, if they're seeking treatment, they're pretty open about it. They'll tell you what their history is, what their medication's on, and kind of what they're doing with it. And that's kind of, I mean, that's kind of nice because most of those guys don't want that. They don't want their mental illness. I mean, they just rather just not deal with it, but it's just something they have to deal with. So same thing, I think, with like any other, solicit permission before beginning assessment. Again, just because they're depressed or manic, obviously they're still people, treat them like people. So. I think I'm going to talk about Down syndrome and we'll kind of cut it. You guys familiar with Down syndrome? Mm-hmm. Yeah. So interesting thing about Down, I had a student that actually used to work with children with Down syndrome. And she was actually kind of funny because she was talking about how they would actually try to manipulate the people trying to help them. You know, they said they taught them one thing, you know, one person would go teach them one thing and then they'd come back and say, yeah, I heard you taught that. Oh, no, I wasn't taught that. So it's kind of funny to see how they're just still, you know, kids still playing kids' games at the same point. But generally, I think with them, they're very passive, very friendly people. And the thing is that they only live till about 30, just to let you know. So how do you think that would kind of, what do you think, for patient assessment, what would you guys want to consider with somebody in that situation?
You would- you-
Yeah.
I mean, let's say if they're like, yeah, like a Down syndrome in his 20s, I mean, he still has like a mind like a child, I guess you could say, kind of in a way.
Depends on severe it is, too.
Well,
I
yeah,
mean, they
some of them
vary.
Maybe,
Yeah.
I mean, I guess you'd have to
Almost
talk to him a little bit.
Yeah, talk to him like a child almost, you know, hey.
Yeah.
And then kind of, you know, if you talk to older people, you know, like an adult, but you would have to kind of,
Yeah, you got to find out what level they're on.
yeah.
You know, what level they're functioning on.
With we have somebody in our family that's got it, and when he was born, he couldn't hear on
Mhm.
top of that. So he learned sign language and then he learned to talk later. So he's really difficult to understand.
Yeah,
Really
I
difficult
bet.
to understand.
So,
But he can pick up who
Very
really,
scavenging.
he can pick up who really likes him and is interested in what he has to say, than people who just say, yeah, and kind of go along with it.
yeah.
He
I-
can tune in on that, like,
And
really quick.
I've actually noticed the same thing with mentally ill people. They're unusually perceptive of other people around them, and they'll be very unusually perceptive about you. You know, so just kind of one of those things of, you know, they might sit there pick up something about you and they'll tell you about it. And you're like, how did
Kind
you?
of freaky.
Yeah, it is. It's kind of like just kind of be forewarned with that. You know, but that's just kind of one of those unique things of nature, I guess. The other thing here is just articulation between C1 and C2 may be unstable. So just remember that if there's an accident or something that, you know, the atlas axis here, actually was it the ondinoid process might be broken. So, I think we're going to leave it from there.